appears on cuffing and straining, which was used to disappear previously or completely on lying down, but swelling at present has decreased but not completely disappear on lying down. Swelling become painful since last 2 years. Pain is of dragging type, radiating to back and increases on standing position, relieved on lying down. Patient had raw area over the lower part of swelling since last 3 months with no complaining of discharge. Patient was operated thrice for lower segment cesarean section by phalangeal incision. First time operated 18 years back with no post-operative complication. 16 years back with no post-operative complication. 13 years back post-operatively patient developed wound gapping with purulent discharge from the suture line, which was managed with regular cleaning and dressing for 1 year. There is no history of difficulty or straining during micturition. No history of recurrent colicky abdominal pain with vomiting or obstipation. Past history: patient is diabetic since last 7 years and hypertensive since last 2 years and taking medications regularly. Personal history: patient consumes mixed diet, normal bowel and bladder habits, sleep and appetite normal. Family history: no significant family history. Summary: 41-year-old lady operated thrice for low segment cesarean section, presented with complaining of swelling over abdomen since last 10 years, associated with dull aching pain and raw area. Patient is known diabetic and hypertensive and on medication.
Madam, you are muted. Please unmute yourself and you can ask questions. Achale, ma'am.
You said there was some discharge coming. What has happened to that?
Purulent discharge came from the raw area.
No, when it was?
It was 4 to 5 on the post-operative day, 4 to 5.
Hello, can you hear me?
Yes, ma'am.
Okay,
Yes,
okay, that's great. Good morning, everyone. Now, please tell me, when was the last cesarean done?
Last cesarean was done 13 years back.
From the same incision, all the 3 cesareans were done?
Yes, ma'am.
Okay, and the last one was infected. There was some
Yes,
discharge.
Yes, ma'am.
So, can you tell me what precautions should be taken when there is repeated more than one time cesarean section is to be done? What precautions should be taken in suturing the wound?
In suturing the wound, the fascia should be closed interruptedly, as there are chances of the chances of the weakness of the facial layer.
What about the muscles of the lower abdomen? Can you tell me some anatomy of the lower abdomen?
In the lower abdomen, the rectus muscle is present on both the sides and inserted up to the pubic symphysis. So we should not cut the rectus muscle as it.
Deepti, can you tell, is the rectus muscle is inserted in the pubic symphysis or originated in the pubic symphysis?
Originated at pubic symphysis.
Yes.
Oh, it is both a different meaning, no?
Yes, sir.
Okay. So you must be very careful when you are saying about that. When you inserted is basically we are talking about the end of it. But here the muscle is originating from here, going
Yes,
up
sir.
and then. Go ahead.
What else? Which are the other muscles in the lower abdomen besides rectus?
Continue with the anatomy, beta. Continue with the anatomy.
The other muscles in the just below is pyramidalis muscle also came.
Okay. Then on the lateral side?
On the lateral side, 3 muscles came: external oblique, internal oblique, and transverse abdominis muscle.
Right. So when you are doing a C-section, what is done with the rectus muscle and these muscles, transversus, internal and external oblique muscles?
The rectus muscle is retracted on both the side at the time of the cesarean section. And the aponeurosis of all the 3 muscles came just behind the rectus muscle.
Just behind the rectus muscle?
Below the umbilicus. Below the umbilicus, is it going be?
What happened?
What
Below
about
the
the
What happened to the rectus sheath in
posterior
that area?
rectus sheath?
Below the umbilicus, all three muscles come in front of the rectus muscle and form the anterior sheath, and
With the
posterior
umbilicus?
to
No, with the umbilicus it is happening.
below the arcuate line.
What is arcuate line? So what is
Arcuate line
arcuate
is
line?
arcuate line is the is present 5 to 6 centimeter below the umbilicus and form the lower margin of the posterior sheath. The posterior sheath
So
ends
5 to
at the
6 margin
arcuate line.
you will have the posterior rectus sheath. Only below that, below the arcuate line, you will not have the posterior rectus sheath. Normally, how the posterior rectus sheath is formed?
The posterior rectus sheath above the arcuate line forms by the posterior lamina of the internal oblique and the aponeurosis of the transverse abdominis muscle.
Okay.
Can you tell me the nerve supply of the rectus muscle, which is very important when we are doing a lower abdominal surgery?
T7 to T12 nerves.
Which nerves?
I
If
don't
you're not,
know.
it's okay. Otherwise, you can go and read it. No problem.
I don't know.
Okay, fine. And what about the blood supply?
Blood supply is from the superior epigastric artery and inferior epigastric artery.
Right.
Superior epigastric artery is coming from where?
Superior epigastric artery came from the internal mammary artery.
Good. Divides into musculophrenic and superior epigastric.
Yes.
Fine. Go ahead.
So Dr. Jailal was asking regarding the discharge. You said there is a raw area over the skin.
Yes, sir.
No. Now only I noted it is for 1 year they have treated. It is not just a wound infection. It is not the patient having a discharge, which patient they were treating it for more than a year.
Yes, sir.
So what is the reason? What is happening there then?
This patient is a known case of diabetic. There is a continuous purulent discharge from the wound.
Here, without any particular reason, there will not be a wound discharging for continuously for 1 year. So some wound ulcer is not healing, especially a peninsular incision is not healing for more than a year. That means there is something wrong with the wound. Something else, either a foreign body or some other that is there. And have you gone into the details of that? Have you just thought it is an SSI and left it?
Sir is asking what is the reason for that ulcer. I think your selection of word is also wrong. I would rather use word sinus rather than ulcer.
Very right.
Yeah. Do you understand, Deepti?
Yes, sir.
So what are the causes of sinus? That is it will become simple. Common cause.
Surgical site infection is the most common cause of sinus formation.
What infection?
Foreign
There are
body is
other
the
causes. There are other causes also for sinus formation. It's not only SSI. There are other causes.
foreign body, presence of foreign body.
Yes, very good.
In
Presence
this
of
case,
foreign
in your
body.
case, and what you are suspecting, a foreign body means what you are suspecting as a foreign body here.
Outside
What is the suture material they would have used? Is it absorbable suture material or non-absorbable suture material?
that I don't know, sir.
No, normally what you do, because it is now, this is happening in the recent years, no? Recent years, what an gynecologist will use for a suture material in this cesarean section?
They commonly use proline or vicryl sutures for the
What
closure
will
of sheath.
happen when the proline is there? Because non-absorbable. And if it is in the presence of the milieu of the infection, and it acts like a foreign body once it is getting infected. So continuously, it will start producing an infection. When it's a foreign body, the granulation suture material itself can be there.
Yes, sir.
That is a possibility there.
Yes.
So probably because you are talking about a case of incisional hernia, so you should, and you have a history of 1 year duration, the wound does not heal. And then you should gone little more deeper into that and ask for the details. Okay, you are not asked, fine. Perfect. Is there any bearing of this now, the present patient developing a symptom and this 1 year history of a wound, non-healing of the wound?
Sorry, sir, I didn't get the question.
No, you said there is a 1 year, there is a problem in the proper healing of the wound.
Yes, sir.
So is there is any relationship with what the problem, what you are facing today and this history?
Think she is not getting it. What sir is asking, look, the previous surgery is done and wound has not healed. So when you are going to operate in this patient, is there any bearing of that past history? Am I right, sir? That's what I think.
Yes.
Yeah. Did you get it?
At present, when we go to treat this patient, it will there will be the residual infection may be present.
Sinus is still present or this is healed now?
Sinus is still present over the skin of abdomen, but on the
Can
other
it be
side of
anything else apart from it is sinus? Look at the patient's condition. Can it be anything else?
it can be intracutaneous fistula.
No, no. Arre.
No, absolutely no.
How can it be? You must have observed that. No. It can be no. It is no.
Pressure ulcer.
Yes, friction or pressure ulcer. Because look at the, it's a falling like a apron. It can create a problem. So it might, then you are justified to say it is ulcer. So friction is another thing because it is remain buried, perspiration, everything can cause. So is that a cause or is it a sinus?
So the friction ulcer is the cause for the raw area.
How can you differentiate between the friction ulcer and
Let
a
us know
sinus?
let us know the examination finding. Okay.
Okay. Dushyant, you were asking something?
Yeah, how do you differentiate between a friction ulcer and a sinus? Then that you are
In
supposed
friction,
to.
the site of the ulcer is present when where the lower waist is present. By that we can differentiate, and in the examination finding, there is no discharge from that raw area, and healthy granulation tissue is present, and only there is a breach in epidermis over the raw area.
Okay, go ahead.
Okay. So shall we go to examination? Actually, not, you should not say epidermis. It should be skin. Only epidermis, it will not be, it is abrasion, then it is not ulcer. Huh?
Yes.
Use
Something
your
you
word
would like to ask
properly.
for negative history?
જયેશ ભાઈ ગુડ મોર્નિંગ જયેશ ભાઈ તમારે કઈ પૂછવું છે ડોક્ટર જયેશ પરીખ has joined.
Good morning. Good morning.
Good morning, Jayesh bhai.
Good morning, madam. Good morning.
Okay, let us go to the.
Yeah, okay.
General examination. I have examined the patient in a well-lit room with proper exposure in presence of female attendant with informed consent from the patient. Patient was well built and obese. Weight is 95 kilogram. Height is 157 centimeter. BMI is 42.7 kilogram per meter square. Temperature is normal. Pulse rate is 90 per minute. Blood pressure is 150 by 90 millimeter of mercury in right brachial artery in supine position. Respiratory rate is 16 per minute. Abdominothoracic. No pallor or edema present. On inspection, I have examined the patient in both supine and standing position. Large infraumbilical swelling hanging over the pubic symphysis, covering the lower abdomen and groin region of size approximately 50 into 30 into 10 centimeter. Swelling is partially reducible on lying down position. Cuff impulse is present. There was no visible peristalsis or dilated veins over the swelling. Umbilicus is stretched out transversely and displaced towards superior and left side. Transverse scar of previous surgery is present 3 centimeter above the pubic symphysis. Scar is stretched out with thinning and discoloration of overlying skin. 2 into 2 centimeter raw area was present over the left lower part of swelling with healthy granulation tissue with fibrotic margin with hyperpigmentation of surrounding skin. On palpation, temperature was normal all over the abdomen with no tenderness. Infraumbilical swelling of size 50 centimeter into 30 centimeter into 10 centimeter present, soft in consistency. On lying down, swelling is partially reducible on its own and increases in size on standing position. On straight leg raising test, swelling became prominent, but defect size could not be assessed. Tone of the abdominal muscle was lax. Expansile cuff impulse was present over swelling. Raw area of 2 into 2 centimeter present over left lower abdomen with healthy granulation tissue with no discharge. Tympanic on percussion, tympanic note over swelling was present. Normal bowel sound was present over abdomen and auscultation. Digital rectal examination is normal. Cardiovascular system is normal and respiratory system is normal.
You are not told about other organs in the abdomen. You only examined the swelling. What else you should have examined?
No organomegaly present.
In leg raising test, can you palpate the muscles? Which side there is a weakness?
No,
Can
ma'am,
you?
I'm not able to palpate the muscles.
Even above the
Deepti,
swelling?
No, ma'am.
Dr. Gandhi here. In your examination, you have written swelling is partially reducible. That means majority of the swelling is not reducible, correct? So when
Yes, sir.
the majority of the swelling is not reducible, how did you feel for the cough impulse? I'm confused. Can you explain me?
As swelling is partially reducible, on cuff impulse, there is a increase in the size of the swelling.
No, but in a swelling which is not reducible, can you elicit a cough impulse?
Yes.
Yes. So is it that it's a visible cough impulse which you see, or you can actually palpate it? Because if the swelling is not reducible, what do you mean by cough impulse? That means something has to come out and you have to see it popping out. Here your swelling is not reducible at all.
The
It's an
even the
irreducible swelling.
video shows the swelling is intact. When the patient is laying down,
Yeah.
training is putting, nothing is going
Yeah,
inside.
and then you're telling me there is a cough impulse. So you're contradicting your own statement. On one side, you are saying it is not reducible at all. That means it's partially reducible. That means majority of the swelling is irreducible. How do you elicit cough impulse? These are two contradictory statements. I would need, so can you explain?
So I think what you are saying is actually the tautting of the abdominal muscles while the patient coughs,
Yes, sir.
right? Basically because it is not reducible. So, and number one, and number two, it's a huge swelling. See, I mean, looking at the patient, the size of the swelling looks bigger than the size of the abdomen,
Yes, sir.
right? So, Jignesh has rightly pointed out, I think that especially when such a large hernias, when it is not reducible, it is because see, what you see is right, but it is because the whole abdomen is moving with coughing. The whole abdomen moves. That is what
Yes,
you are
sir.
seeing as a cough impulse, not the actual cough impulse. This is what I feel.
So there's a movement of the whole abdominal wall when the patient is coughing, and that is not cough impulse. Cough impulse is related to the swelling. That means the swelling has to disappear and appear, and you can see the swelling going up and down. You understood?
Yes,
Here,
sir.
you cannot see that. It's a whole movement of the abdominal wall when the patient is trying to cough. So
Yes,
never
sir.
ever comment on a cough impulse in a swelling which is irreducible. That is a rule of thumb. Okay,
Yes, sir.
and this applies to any hernias, even in the groin. So people have sometimes elicited certain tests also on this swellings. So the basic criteria for any impulse on coughing or performing any test is that the swelling has to be reducible. Only then you can comment on that. Okay,
Yes, sir.
continue. So what is your final diagnosis you mentioned?
You said
Deepti?
you are not able to find out any defect, no? You said you are not able to find out any defect.
Yes, sir.
And
I'm not able to palpate defect.
where do you look for the defect? You said there is a transverse scar. Are you going to have looked into the defect there, or anywhere else you have seen the defect?
All over the swelling in the all over the scar also and above the scar also.
So there, what kind of a defect you will see?
In this case, I will be able to see the horizontal defect as well as the vertical defect and the linea alba.
Is a defect in the linea alba or divarication of recti you are going to see?
Both can be seen, sir.
No, what you have seen, but what you are look for.
I will look for the divarication of recti first.
So in this case, there's no divarication of recti also.
I'm unable to see because of the huge swelling.
That is why Achalya ma'am has asked you whether you are able to palpate the muscles or not.
No, sir, I'm not able to palpate the
So,
muscles.
so that gives you a gauge of the size of the defect, right? I mean, there are two important things. One is the area or the size of the defect, and second is the volume of the hernia. When we plan any kind of repair in a patient, these two things are very important, right?
Yes, sir.
I think
A
another
little
point
more
over
exertion in the
here.
palpation should have given you more information. Like when it is partially reducible, you reduce it to the extent it can be. And then put your two fingers on the swelling and ask the patient to cough. If your fingers move up and apart, that means there is an expansile cough impulse. Isn't it? This is a very basic test which we can do. Number one. Number
Yes, sir.
two, the swelling may be very big, but once you are doing a leg raising test or head raising test, some of the muscles on the upper side also or on the lateral side of the swelling should be palpable and you should be able to feel the tone of the muscles. Have you done this?
I have
Madam, sorry to interrupt you because it's my patient. Swelling is so large and so huge and
Okay.
so mushrooming is there in spite of straight legging or anything.
Nothing would
He
happen.
will, it was impossible to palpate the muscle anywhere.
Absolutely.
So whatever she should have clearly said, it is impossible to palpate the lateral edges because we don't know how much large gap is vertically,
It's a
horizontally.
huge gap. That is, and definitely she would not have palpated the muscle, but she said she was able to feel the muscle. That is what the problem comes.
But that is wrong. It is a lateral part she is feeling, not the actual
Okay.
age of the gap, which is impossible to feel. She is confused there.
Actually,
It is not the age of the muscle, sir, is asking. That will decide the gap. But actually, what you are feeling is the lateral muscles, not the age of muscle. It's impossible. Sorry to you.
yeah, another point over here is the patient is 45 plus BMI. And in
Yes,
this
sir.
patient, it is really, the patient has a thick penis, right?
Yes,
So it's again like it is it's a hurdle for filling that muscles.
Yeah, very right. With 45 BMI, it is very difficult to feel the muscles even.
Go ahead.
Summary of my cases: 41-year-old lady operated thrice through lower segment cesarean section by phalangeal incision, presented with swelling over abdomen since last 10 years, associated with dull aching pain with raw area over the skin of swelling. Patient is a known diabetic and hypertensive and on medication. On examination, infraumbilical swelling of approximately 50 into 30 into 10 centimeter, partially reducible on lying down with expansile cuff impulse present over the swelling. Scar is present over the lower abdomen, stretched and thinned out with discoloration of the overlying skin.
So diagnosis?
My diagnosis is complex, partially reducible large incisional hernia with loss of domain with bowel and omentum as its content.
Why bowel
Why
and
did-
omentum? You said there is no peristalsis?
Why did you use the word provisional? This is a clinical diagnosis.
Yes, sir.
Hello.
Yes, sir.
Why did you use the word provisional? It is clinical diagnosis. Have you doubt about your diagnosis about incisional hernia?
No,
Then
sir.
why you use the word provisional? It
So
should be the
better-
clinical
yeah.
diagnosis.
Yeah, so it
Yes.
should be clinical. That is fair enough. Okay. Right, sir. Yes, ma'am, you were
Yes.
asking something.
Is there
The
any
swelling is
differential
appearing-
diagnosis? Is there any differential diagnosis also?
Any soft tissue sarcoma tumor may also present like this.
Deepti, you should say no. Do you think it is a incisional hernia or soft tissue sarcoma?
It is incisional hernia, sir.
So you can always put your foot down. No, ma'am, this is incisional hernia. You don't need a differential for this.
Yes, sir.
Is
the
there any
swelling is
feature which suggests this
overduplication?
can be a sarcoma? So you should not consider it. Now you are a PG student, not a UG student. So
Yes, sir.
you should think of plausible differential diagnoses.
Yes, ma'am.
Okay.
Yes, Tushan.
Yeah. See, what I'm asking is that thrice the cesarean section is done through phalangeal incision.
Yes, yes, sir.
right? And according to your history and examination, I make out that the swelling is intra-umbilical,
Yes, sir.
right? So you do you feel that it is coming out through the incision, or can it be lower rectal divarication only?
The swelling mostly coming from the divarication of recti present below the umbilicus, but the weakness occur at the scar site.
So do you feel that clinically it is incisional hernia with the muscle divarication or something?
Yes, sir.
Deepti, what is divarication?
Divarication of recti is gap in the rectus muscle which is less than 2 centimeters.
Gap in rectus muscle.
Thinning of rectus muscle with
Oh, no, no, no.
in linea alba.
Right. So do you think it is the divarication this patient has? Huh? How will you differentiate divarication from incisional hernia? If at all there is a one differential diagnosis, might be divarication, not in this case, but at all. So what is difference between divarication and actual incisional hernia?
In straight legging test on divarication of recti, there will be bulging in the midline, and there is no
So
defect is
pure divarication is not a hernia. It will remain in reduced state. You will be able to observe it when you contract the rectus muscle. So
Yes,
this
sir.
is definitely no divarication. But from where the hernia has occurred? Remember, do not loosely use word divarication. Separation of recti is there. So from where the hernia has appeared? That's the sir is asking.
From the scar of fenestrial
The
incision.
scar is no, you say scar is lower down. So do you know how the cesarean section is done? Tell me.
In cesarean section by fenestrial incision, uh, that is incision is placed 2 to 3 centimeter above the pubic symphysis,
Yes.
where they have.
And what they do to anterior sheath then? Aponeurosis.
They cut the anterior sheath.
Transversely cut. Then what?
Then retract the rectus muscle on both the sides.
The point is that they elevate the upper flap of rectus. Many a time, while elevation, there might be injury to anterior sheath. One. Second, what they do, they separate the rectus muscle forcefully. And then sometimes they do not come in position and remain. So actually it is hernia from upper part of the separation of rectus muscle. That is causing the problem. And the aponeurosis might have been injured that time. So it's an incisional hernia coming from, not from the scar itself, but coming from the incision site itself.
And second thing, when there is a repeated incisions at the same site, there is a lot of fibrosis. And when they are doing the cesarean section, they want some space to deliver the baby outside. So they are doing a lot of stretching. And sometimes a lateral dissection also, or sometimes there may be some rupture of the fibers of the rectus muscle and damage to the nerve supply also. That can be the reason for the weakness in the tone of the muscle, and this can also cause the herniation.
Yes.
So, what investigations you would like to do in this patient?
I will first go for the routine investigation, then go for the RBS check and HbA1c of the patient, go for the pulmonary function test, ECG, and 2D echo of the patient. And apart from this, I will like to go for X-ray of chest and abdomen and dynamic CCT of abdomen and pelvis.
What else? Anything else? Why you want to do dynamic CCT of the abdomen?
In dynamic CCT, we will be dynamic CCT is the CT scan when the patient is not still, and we are able to do it when the patient is moving at the time of cuffing or valsalva. So we will be able to see the exact size of the defect, condition of muscle at the time of the cuffing, and volume of the sac and the volume of abdominal cavity also.
Do you have the plate?
Yes, sir.
Just put it up. The cross section.
What does it show? Explain it.
In this slide, I am able to see the rectus muscle of both the side, which is thinned out. On the lateral side, I am able to see the three muscles from outside to inside: external oblique muscle, internal oblique muscle, and transverse abdominis. On the
Can you
anterior
move the
aspect,
cursor on it, Deepti? Move your cursor on it if you can do it.
yes, sir. This is the rectus muscle of this side.
We can't see the cursor. Can you move it on this film? Is it possible? Okay, fine. If it is not possible, this is marked on the plate, so you can explain it like this only.
It is on the arrow, I think.
Yeah.
On the lateral side, external oblique, below it is internal oblique, and below it is transverse abdominis muscle. On the anterior aspect, the one sinus tract is present just above the midline, and the defect is seen just behind the sinus tract, and the bowel loop is present just behind the defect.
So lateral, the recti are quite apart from each other, and gap is midline. Central gap is in this cross section. And
Yes,
in the
ma'am.
longitudinal section, how big is the gap? Explain it.
The hernia sac is starting from the infraumbilical region and covering all over the abdomen.
So vertical defect is more than the horizontal defect.
Yes, ma'am.
Is it?
Yes, ma'am. Vertical defect is more.
So how many plates the defect is seen?
The defects start when the plate is just below the umbilicus, from where the defect started.
Yeah, I
And
think,
going up to what?
yeah, this one is quite a big defect.
Going up to the when we are able to see the femur head
Above, superiorly?
superiorly.
So superiorly up to umbilicus, right? Or how many centimeters below umbilicus?
Below umbilicus, it is around 30 centimeters.
Okay. Above the umbilicus, the recti are not apart. They are close to each other.
They are thinned out, ma'am, but also apart.
Also apart and thinned out.
Yes,
Okay.
ma'am.
So both things are there. The recti have moved apart and they are thinned out also, causing a
Yes,
lot of
ma'am.
weakness in the muscle.
Yes, ma'am.
So what can be the reason of thinning of recti?
Due to continuous stretching and increase in intra-abdominal pressure, on a long term, it will lead to the thinning of the recti muscle.
Other causes? Something to do with BMI? Something to do with diabetes? Something to do with other deficiencies?
When there is high BMI, there is a thick pannus, thick tissue, thick subcutaneous tissue that will also lead to the pressure inside. And in case of diabetes, there is a poor collagen formation and
Yeah, there you're going on the right track. There is poor collagen formation. So the muscles becomes very weak. And due to obesity, the fat also goes in between the fibers of the muscles. That also leads to a lot of weakness in the muscle.
Yes, ma'am.
So this is not only the incision which is causing hernia, there are other factors also for this huge hernia.
Yes, ma'am.
And once you try to treat the patient, you have to consider all these factors so that it
Yes,
doesn't
ma'am.
recur.
Yes, ma'am.
So the last years was that before 10 years. Hernia
Yes,
started before 3 years. Okay. So there are other factors than just the incision,
yes,
right?
sir.
Which have come in play, right? So
Yes, sir.
madam exactly asking which are those factors.
Other factors in this case is the BMI and the weight of the patient. Patient is a known case of diabetic and hypertensive, and these are the factors which also lead to the weakening of the muscle on both the sides. And due to the weakening and thinning of the muscle, and due to the defect present above the scar side, and the and due to continuous pressure, and due to the thick subcutaneous tissue.
You have gone for thyroid profile of this patient?
Yes, sir. We have gone for thyroid profile of the patient, which was normal.
Okay. And what about some vitamin deficiencies? Have you thought of checking vitamin D? Has it something to bear? Vitamin D?
I have not checked, ma'am.
Should you?
Yes, ma'am. I should.
Vitamin C?
Yes, ma'am. Vitamin C and D, as the collagen formation and the maturation is dependent on them.
And some micronutrients like zinc, manganese, iron.
Yes, ma'am.
Should you consider all these things?
Yes, ma'am.
Have you done the liver function test, serum
Yes,
proteins?
yes.
Did you spoke? I don't remember. Did you speak about liver function tests?
No, ma'am. I didn't spoke.
Is it important?
Yes, ma'am.
Very important. You see, as a surgeon, you are not going to only operate, but you should see that it should heal,
Yes, ma'am.
because this is a very complex problem for the patient. So all effort should be done so that when you operate, it should be successful. So you should investigate on all these lines.
Yes, ma'am.
Dr. Jairaj, sir, anything from your side?
No. Just one question. What complications will you expect if you reduce such large hernia?
If I try to reduce such a large hernia, it may cause the entrapment at the neck region, which may further lead to the obstruction. And as I am suspecting adhesions in this patient, as the swelling is partially reducible, it may cause the bleeding or tear of that adhesion.
Okay. Another thing, what will be the effect on respirations? Why do you want the Tanaka index on CT scan?
As we are seeing the patient, we are suspecting that the patient is having huge swelling with suspecting loss of domain. So will calculate the Tanaka index so we can plan our management. As the Tanaka index, if it is more than 25, we have to go for the component separation and consider other methods of management like preoperative progressive pneumoperitoneum or Botox. So intraoperatively, we will be able to close the defect without much more tension.
So, by the way, what is Tanaka, beta? You said
The
Tanaka.
Tanaka index is the measurement of the volume sec with in relation to the abdominal cavity.
Show it on the
The,
CT scan.
in
Now,
the in the second plate, we are seeing the defect and the volume of the sac in front of the defect and the abdominal cavity. The volume of the sac is comparable and more, and the Tanaka index in this patient is 0.37%.
So do you expect post-operative respiratory distress in this patient after reduction of bowel in the
Yes, ma'am.
abdomen?
Yes, ma'am.
What will you do for this?
For the preoperatively, I will go for the increase in the abdominal pressure by creating the preoperative progressive pneumoperitoneum. So the increase in the abdominal capacity may increase.
How do you
Botox in
create it? How do you do it? Have you
in
seen
the
complaints?
ma'am, I have not seen it, but I have not seen it ever.
पंकज भाई थोड़ी रोशनी डालिए.
Madam, sir had to leave. He'll be joining soon. He just gave me a call.
Okay. अपूर्व आप डालिए कुछ रोशनी इसके ऊपर कैसे मैनेज करेंगे इस पेशेंट को. It's very complex patient for her.
Right, ma'am. But I think they could do it. But the options, what are the options?
The options are preoperative progressive pneumoperitoneum and botulinum toxin injection. In preoperative progressive pneumoperitoneum, at the Palmer's point, we inject the varus needle, and under guidance, we inject 500 to 700 ml of air on post-op on day 1. Then we'll go for progressive insufflation of the air in abdominal cavity for around 10 to 13 days. Since when the abdominal girth of the patient on the previous day was same, and stop the insufflation when the patient feel discomfort or dyspnea.
Dushyant?
Right.
Yeah, so like PPP is one kind of like a very painful condition for patient as such. As she already mentioned that regular interval we have to increase the intra-abdominal pressure with air insufflation until the time patient feels discomfort. We have to just go on filling it up. That
Yes,
is to increase the abdominal volume by stretching the transverse muscles on the sides of rectus. That's the main criteria for this, right?
yes.
So PP is like initial first this thing procedure is done in operation theater under all precautions with anesthetists around, and SOS laparoscopy is kept ready to rule out any intra-abdominal problem. Follow-up insufflations can be done on as a ward procedure or the bed procedures, where you can just go on increasing the pressure gradually and feel the discomfort. And once patient feels that, okay, you can just go on releasing that. And that's a very progressive and slow procedure, right? And that's how the volume can be increased, right?
The
And another thing is botulinum. Botox. Yeah, can you just elaborate on Botox?
the Botox is botulinum toxin A, which is a presynaptic cholinergic inhibitor. When we inject the Botox, the main principle behind injecting is elongation and relaxation of the muscle of the lateral muscle of the abdomen. So we will be able to close the fascia. In botulinum toxin A, total 300 to 400 units can be used. It will be inserted on both the sides of the abdomen at the 3 points on each side, and will inject it into the external oblique, internal oblique, and the transverse abdominis muscle.
No. Which is the plane of nerves where the nerves run
Nerves are
in the
presented between
transverse.
internal oblique and transverse abdominis muscle.
Okay, so what's the fun is giving injection in muscle, right? Okay, so your point of view, it is not multiple places, it's 3 places between the internal and transverse. Okay, 3 on the each side.
Yes.
All right, go ahead.
So
So you one injection like at one place. How much injection is given? You have to give total 6 injections at a time,
Yes, sir.
right? And
Around-
what precautions you are supposed to take while giving the injection?
First, I have to give the test dose to the patient to see any allergic reaction. Then I will give the dose.
You have to
what
give it
will
a
be the
USG
key point?
guidance.
Sorry, sir.
Which are the 3 points, and should you give it under USG guidance?
The 3 points will be selected in between the costal margin and the anterior superior iliac spine.
And is it done USG guided or
It is
without?
done USG guided.
Okay. And what precautions you take where you should not inject?
I don't know.
Near the blood vessels. Otherwise, this will cause some hematoma and that will be disastrous.
Yes.
Okay.
Okay. And how much gap you are supposed to give after injection and surgery?
The peak of the botulinum toxin came after 4 to 5 weeks.
So you are supposed to wait from 6 weeks. You have to operate up between 6 weeks to 12 weeks time,
Yes, sir.
right?
Yes, sir.
Base time is about the peak time. Okay. So you
Yes, sir.
cannot operate, just give today and tomorrow you cannot operate.
Yes.
Okay.
What about the fat layer in the abdomen? Is it very fatty, this patient? Abdomen
Yes,
is
ma'am.
fatty.
Yes, ma'am.
How thick is the fat layer? Approximately.
Approximately 8 to 9 centimeter, ma'am.
8 to 9 centimeter is the fat layer.
Yes, ma'am.
Too thick.
So, would you like to do liposuction before going for hernia repair?
Yes, ma'am. We can go for liposuction before.
What is your advice, Dushan?
Ma'am, I will go for bariatric rather than liposuction as such because the patient's BMI is already 45 plus,
Yeah.
right? And like we are dealing with the condition much near to this compound separation or something, like the
Yeah.
patient has loss of domain and everything. 45 plus BMI, this large hernia, there are chances of recurrence very high, right?
Very high, very high. Yeah.
First, we have to tackle with the obesity, where the patient has 45 plus BMI. If patient agrees to that, we can go for a bariatric surgery. We cannot go for gastric bypass as such because the bowel is inside the sac, right?
Right.
So at least we can go for some kind of restrictive bariatric procedure, right? And then we can plan out the same way what we plan out for botulinum toxin or PPP. Like we can plan for like 3 months gap, and once patient loses some weight, right? We can plan for this surgery. That would be good for both the respiratory like problems also can be sorted out, and post-operative abdominal pressure can also be sorted out.
Very right, very right. And what type of surgery you will do, Deepti?
In this, I will go for mesh plasty with posterior component separation.
Which mesh
So would
you
you
would
like
like?
to observe on table or it's predetermined that you will go for component separation?
I will plan for component separation pre-operatively as there is a loss of domain.
All right.
How will you do component separation?
In posterior component separation, we are going to release the transverse
Basically,
abdominis.
what is the idea of component separation, Deepti?
The idea of component separation is to close the defect, close the facial defect, maybe the posterior sheath or the anterior sheath.
By
With primary closure without tension.
so what do you do laterally? Either it is anterior or
How do you get
posterior.
that?
What is that?
Laterally, we are going to free the lateral muscle, so the attachment of the fascia with the lateral muscle release, and so we are able to make the fascia close and able to close it.
So
Which
there are
fascia you are
basically
talking
3
about?
layers. Yes, ma'am. What?
Which fascia you are talking about?
The anterior sheath and the posterior sheath.
Okay, so anterior sheath is separate and posterior sheath is separate. In the lower abdomen, there is no posterior sheath. Isn't it? Linea semilunaris के बाद में तो posterior sheath होती नहीं है नीचे.
Yes, ma'am.
तो posterior separation अगर आप करेंगे तो plane कौन सा रहेगा फिर? In between what?
will be hybrid plane, ma'am. In the above the arcuate line, it will be the retractors plane, and below it will be the
Retrorectal.
pre-peritoneum. Sorry, ma'am.
Retrorectal and preperitoneum.
Yes, ma'am.
Okay. So all the three muscles would be above the mesh. You want to say that.
Yes, ma'am.
And where is the neurovascular plexus? In which plane it is lying?
It is lying between the internal oblique and transverse abdominis muscle.
Yes. So you are very right that you should not disturb this plexus. Otherwise, there will be ischemic necrosis of the remnant muscles.
Yes, ma'am.
You have to preserve the vessels, you have to preserve the nerves when you are separating the components. That's very important thing.
Especially below umbilicus, where you get the inferior efficacy almost in the
Yeah.
same plane.
Yes, sir.
So, were you able to close the peritoneum?
Yes, sir.
Okay. Supposing you don't, if it is not possible, what you should do or what you can do?
At the time of the dissection, I will try to save the sac as much as possible. So after that, we can use the sac to close the peritoneum if we are not able to close it without tension.
Right. Or in other cases, that is also not possible. You can put in a double layer mesh also.
Yes, sir.
That is a good option.
The sac is very big, so there is a lot of peritoneum. You can save it.
Right.
The
So one
problem is
part
with
is
muscles.
surgery. One part is the surgery, the second part is to bring the patient out of the ventilator.
Yeah. And the post-operative period is going to be smooth or not smooth?
In post-operative period, we have to electively intubate the patient. We have to continuously monitor the intra-abdominal pressure of the patient and monitor accordingly.
Yes.
How do we do it in our setup?
Measurement of intra-abdominal pressure is done by per-urethral catheter. We insert 20 to 25 ml of saline via the per-urethral catheter and place the setup at the heart line, and will measure the height of the column movement, and it will be measured in centimeter of H2, and we will see the grading of the abdominal pressure according to that.
What is the normal? At what level you should keep it?
Normal level is 8 to 12 millimeter of mercury.
What about her diabetes, hypertension, and other factors? How will you regulate, control all these factors so that your healing is good?
Preoperatively, I will first give the patient instruction of the weight reduction, so it will be feasible post-operatively. Continuous diabetic control of the patient on medication with lifestyle modification. Along with that, for the hypertensive control, regular exercise along with the medication, first to be managed preoperatively, and then post-operatively will make the diabetic control and blood pressure monitoring post-operatively.
We discussed that there's some problem with the collagen synthesis probably in this patient. That's why there is such a huge hernia. Nowadays, collagen drinks, collagen powder is available. What is your idea about this? Would you like to give it to the patient?
No, ma'am.
Why?
I have not
I would
seen
like
it.
to ask Dushyant. Does it helpful, Dushyant? It's difficult for you to say because it's not written in the books. Dr. Dushyant.
Ma'am, actually, it doesn't help much because, and again, it will take quite long time for this to build up the thing. Because nutritional supply, once you have consumed and it's going to be there. So, like already the patient has lot of domain having sinus and ulcer and everything. I think we are supposed to deliver the result early rather than waiting for long.
Right.
I think the best modality, as Dushyant already said, was some kind of bariatric surgery,
Yeah.
wait for 6 to 8 months and then go for an incisional hernia repair. Dushyant, how long do you wait after bariatric surgery for incisional hernia repair?
See, in emergency cases, we wait for at least 4 to 6 months, right? Right, urgency, not emergency as such. We can't say emergency, but urgent cases, like we can wait. And weight loss is up to 12 months of time, right? So optimal time is to wait for 12 months till the time patient loses actual weight. We have the fixed modality of patient's BMI and everything. And ideally, we should go for surgery after 1 year, 1 to 1.5 years.
So, as far as bariatrics is concerned, what type of surgery would like to offer to this patient, considering
See, particularly
this patient?
as I mentioned, that patient has a lot of bowel contents in hernial sac, right? And we are expecting a lot of adhesions, right? So this patient doing gastric bypass will lead to big complications because we have to mobilize the whole bowel and we have to attach it to stomach. So for this patient, sleeve gastrectomy is going to be a standard procedure so that we can give restriction, we can give weight loss. This patient will not disturb the hernial sac and the other things, right? Patient loses weight and then second stage we can go in and operate.
Okay. What about putting a balloon, gastric balloon?
Balloon gives a very limited weight loss. I said that they said that it's about 7 to 10% of excess weight loss is given by balloon. So the patient is around 97 kilos. We expect around 7 to 9 kilos of weight loss after balloon. I think that won't be much optimal for this patient, right?
Okay.
This patient should have at least more than 50% of weight loss, excess weight loss. According to BMI, we say this patient has at least 35 kilos of excess weight to her normal BMI. So we are supposed to do anything around 20 to 25 kilos of weight loss.
Okay.
And yeah, optimal would be like only this much of his whereas his procedure can give.
Good, good, good. Okay. And after doing a sleeve gastrectomy, I think our diabetes is also going to be under control.
Yeah, exactly, ma'am. Diabetes is also going to taken care of. Her sugar is also will better controlled. HB1AC will come down, and main thing is abdominal muscle tone also will be better.
Will be better,
Uh, uh,
yes.
yeah. Uh, Another thing which goes in favor of sleeve gastrectomy is not much nutritional deficiencies after sleeve gastrectomy in comparison to gastric bypass. So even already when we are talking about some micronutrient deficiencies, which can lead to collagen problems and everything, uh, sleeve will help in that way that there won't be much of nutritional deficiencies after sleeve in comparison to bypass.
Right, right, right. That's good. That's right.
Jayesh bhai?
जयेश भाई सोई गया?
नहीं मैडम म्यूट था.
मैदान
अच्छा,
में
म्यूट
आओ,
हो गया
मैदान
था.
में आओ.
So one question, why measuring intra-abdominal pressure, you have mentioned using of the Foley's catheter, but where
Yes,
will
sir.
you insert the Foley's catheter?
Periurethral Foley's catheter.
Periurethral. It is periurethral
Yes, sir.
or anything else? It is not within the abdomen other than bladder.
The other methods can be with the abdominal.
Within abdomen. What will you attach with the catheter to measure the pressure?
IV set, sir.
IV set. So you have to describe the complete procedure, how to measure it.
The measurement of the intra-abdominal pressure. First, we'll connect one pint with the IV set and inflate 25 ml of saline into the periurethral catheter, and will block that pathway and connect another with the help of three-way connector. Will connect the another IV set and will see the rise of the column movement in that IV set. That will indirectly that will measure the intra-abdominal pressure, the height of the column movement.
So you have to put
And
a
at,
manometer na, to measure it.
Yes, ma'am. We can put manometer also.
We
It's
have to
available.
build. नहीं तो measure कैसे करेंगे? मैनोमीटर के बिना कैसे मेजर करेंगे? कोई स्केल तो रखना पड़ेगा ना?
Yes, ma'am. scale. By the scale, we can measure the centimeter of H2 and can convert into the millimeter of mercury after that, if manometer is not available.
Yes. Okay, anything else? I think we have discussed a lot.
Yes, Jayesh bhai, Dushyant. I
No,
think
no,
Dr.
no, no
Jailal
further
has left.
question.
Dr. Jailal
No
sir.
further question.
Nice presentation. You have done good hard work.
Thank you.
Okay, ma'am. Jayesh bhai, then we shall leave. Dushyant, will you
Yeah,
guys?
we can leave.
Yeah.
We can leave.
Okay,
Okay.
okay. Thank you, ma'am. Thank you,
Good
sir.
day. Have a nice Sunday.
Fine. Okay, thank you.
Thank you.